Okay, I think we are live. I hope so, at least. Hi, everyone. I'm Dr. Patrick Foye. I'm the director of the Coccyx Pain Center here at Rutgers, New Jersey Medical School. And this is a Facebook Live session today, November 15th, 2020, because today is Tailbone Pain Awareness Day. This is the third annual Tailbone Pain Awareness Day, and every year I do a Facebook Live session so that I can answer questions for people from around the world that have questions about coccyx pain, tailbone pain, coccydynia, coccygectomies, all of that kind of thing. I do need to be clear that this is not considered medical advice. This is general medical information or education. So obviously for individual personal medical advice, you should talk to your personal treating physician or healthcare provider. But really there's lots of things that people don't know about tailbone pain or questions that they can't get answered through their local clinicians because they may not have much experience. So really it's an opportunity to ask those general questions, and I can give you educational content and answers, and sometimes if you post, I can post some links to some things that can be helpful for you to follow up and read about and ask your in-person treating physicians about that. One other thing to note, just that as you post your questions down below, do recognize that, of course, this is the internet, this is Facebook, so it's not completely private by any means. You may want to keep your questions general enough that you're not revealing any more personal information than you want to have out there on the internet. But with that said, I did get a lot of questions in advance, those I will be talking about, and I'll be weaving in the questions that I get now during the actual session here with you. Also, just in terms of respecting your privacy, a few of you are saying hello in the comments section, so I do see those and keep those coming. Great to hear from great to hear from you, I won't be calling you out by name just because this video will be available, afterwards on YouTube or Facebook or wherever. So I will do my best to not say your name just so I can respect your privacy while still answering your questions. And then similarly, by the way, I do not use really Facebook Messenger, so ask your questions here. I can't give private medical advice on social media. And then the one last thing before I start getting to your questions, somebody here in Canada says, "Thank you for the free release of your tailbone book." Yes, the book is available for free on Amazon. So if you go to Amazon, you can get the book for free. Essentially all day today, which is Sunday, November 15th, 2020. If you go to Amazon and you put in tailbone, the word tailbone, and my last name, which is Foye, F-O-Y-E, it should give you that. It'll give you the link right there, and you can get the book for free there. I may be able to post the. Let's see if I have the link. To post the link to the Amazon page, that has that as well. But you can find it. You can find it on Amazon. So with that said, let's see. All right, here I do have that. I can post the link in the comments section right now, and that is the link for the to get the Amazon book. Within the United States. However, it should be available worldwide for free today. So I will post the link. I have a web page where I have the links for Amazon throughout the world, so you can pick up your free copy. If you already have a free copy, please post a review. Someone hello from Scotland. Greetings to you back in Scotland. I'm glad you have that you have my book there. I love Scotland. I've been to Scotland. It's absolutely gorgeous. So let's do this. Let me take a look through some of the questions. First I'll go through a couple of the questions that I have. I copied down a few things from. I made a few notes from things that people were asking beforehand. And sometimes the questions, by the way, they scroll by pretty quickly. So if you ask a question and I haven't gotten to it in a while, feel free to copy and paste it and drop it back in again. Somebody here says, my pain management doctor advised me to take 3 Advil around the clock for 3 days, 9 a day for inflammation and edema around the tailbone. Have you seen this work? So the things I would say is that Advil, which is a anti-inflammatory medication, a non-steroidal anti-inflammatory medication, and those medications can be helpful for acute inflammation, acute meaning something that has happened recently. But there is a problem, of course, with with taking those long term, because the longer term that you take them, the more likely you are to run into side effects. The non-steroidal anti-inflammatory medications like Advil, Motrin, ibuprofen, Aleve, Relafin, etc. They can cause problems such as bleeding ulcers in your stomach and intestines, and gastritis or stomach irritation, things of that nature. In addition to causing problems with the kidneys, and also some heart and stroke-related events, particularly when taken long-term. So if somebody has short-term pain, the anti-inflammatory medications might be fine. If you fell and bumped your tailbone and it's sore for a couple of days, just like if I sprained my ankle, taking an anti-inflammatory for a couple of days, might be fine, as long as if I didn't have any medical contraindications. But and certainly it sounds like you're doing that under the advice of your treating medical physician, which is of course always the best way to do those things. The issue starts to become what happens when the pain continues. And for those of you with tailbone pain, unfortunately, many of you know firsthand that often it's not as simple as, hey, I stubbed my toe or I sprained my ankle, and in a few days or a week or two, it's doing fine, and in a month or two, I don't even remember, which toe or ankle it was that I injured. For the tailbone, it can be notoriously chronic or long-lasting. That would be the issue in that you don't want to be taking typically medications like Advil, Motrin, ibuprofen, Aleve, etc., naproxen, for many months and years, because the longer you're taking those medications and the more frequently you're taking them and the higher dosing you're taking them, the more likely they are to cause some of those side effects that I mentioned earlier. Okay. Let's see. So other questions and comments here. Is there hope for treatment for tailbone pain except for surgery? Absolutely. The vast majority of people who have tailbone pain do not need surgery. In fact, most people, will have a short-lived course. Again, that's not what we typically see in my practice, because the people who come to see me are the people who have had long-term pain, right? Somebody who has, who bumps their tailbone and it's sore for a couple of days or a week. They're not flying into New Jersey or driving into New Jersey to see me at the Coccyx Pain Center. They have short-lived issues. But even among the patients, who have pain substantial enough that they come to the Tailbone Pain Center to see me in person, it's only about 2 to 3% of my patients that I end up referring for surgical consultation. So the good news is that most people do not need surgery. Certainly the one exception to that rule would be if somebody has a cancer, a significant malignancy that's causing their tailbone pain, which is certainly not the majority of people with tailbone pain, but can be detected on MRI and such, particularly chordoma, which is unfortunately commonly fatal. But that's the exception and not the rule. So we screen for those things, of course. And those, so some of those patients may need surgery, or the small percentage of patients who fail to get adequate relief despite all of the non-surgical treatments that are available. The book, for example, is 272 pages. The first half of the book is all about or half of the book rather is all about non-surgical treatments that are available. So that's everything from certain types of cushions. Donut cushions are usually not as good as the wedge cushions. So there's cushions, and there's sometimes pelvic floor physical therapy can be helpful. Sometimes putting medication locally can be helpful by a small local injection, which is a lot of what I do and a lot of what I've published on over the last 20 some years now. So the good news is that for the majority of patients, surgery is not necessary. Okay, so let's see other questions here. Will an anterior dislocation of the coccyx make the levator ani muscle spasm? And due to the dislocation, is it possible to have a vaginal spasm? So this is a great question. The pelvic floor, I'm going to hold up a model here just so you can sort of see. Hopefully this will show up okay. So basically this is a plastic model of the pelvis. And at the back of the pelvis here is the sacrum, and then down here is the coccyx or tailbone. And the pelvic floor is basically a whole constellation, a whole group of muscles and tendons and ligaments that make up the pelvic floor, so that when we stand up from the chair, that our pelvic contents, our internal organs don't just fall down and splash onto the floor or something. They're all held there. It's almost like a hammock or a sling or a trampoline, like holding all of our pelvic organs inside. And if I look this way, kind of looking through the pelvis, basically I'm going to try to look at the camera through the pelvis, and you can see how the tailbone or coccyx right here is one factor that's sort of obstructing the pelvic floor, which is an issue when for women who go into labor and delivery. If my fist here represents the head of the of the child passing through the birth canal, let me hold this at a little better angle here. Then you can see how the tailbone is sort of in the way right there. But anyway, back to your question, which is about the levator ani muscle and vaginal spasm. Well, all of those pelvic floor muscles, that attach, right down here, and they're in multiple different layers. Many of them, not all, but many of them do have attachments to the coccyx or tailbone here. And then what happens is that two things. Number one, there's this chicken and the egg phenomenon, as I often refer to it, is if the tailbone is in pain, whether that's because of arthritis, fracture, dislocation, bone spur, hypermobility, instability, you name it. If the tailbone is in pain, you have all of these muscle groups that are attaching there, and they can go into this reactive muscle spasm. Just like the same way that if I injured my wrist, and then because my wrist was in a lot of pain, because of that, if I'm hiking my shoulder and I'm sort of guarding and I'm kind of like this, all of a sudden I'm going to have a lot of muscle spasm throughout my shoulder and neck region, even though the problem was down at my wrist. So even though the problem, may start at the coccyx, a lot of times these pelvic floor muscles, on each side and throughout the pelvic floor may start to go into this, reactive, painful muscle spasm. So along those lines, often what we see is that in many cases, if we can help to quiet down the tailbone by treating the tailbone pain, if that's the underlying primary pain generator, then often, the other issues, the pelvic floor may quiet down on its own. In other instances, pelvic floor physical therapy can be extremely valuable at helping to work on, some of those, muscle issues in terms of the spasm and pain that can be present throughout the pelvic floor. And that includes the levator ani, muscle, which is a muscle that basically goes from the pubic bone up in the front of the pelvis, and basically, from just inside the pubic bone here, and then it swings back and actually attaches, it actually swings around the lower part of the rectum where your stool comes out when you have a bowel movement, and then it basically holds that in place. And can it cause the vaginal spasm? As I mentioned, it can cause spasm throughout the pelvic floor, and throughout the pelvis, and the vagina, and even the uterus, and the urinary bladder, and even the rectum. All of these are structures that have muscular components to them, and those muscles absolutely can go into spasm. Okay, someone here is asking, says, I fell and broke my coccyx a year and a half ago. I have a small dislocation. I feel spasms and pain, although not very strong, especially when getting up from a sitting position, which actually we should definitely talk about that point, the pain with sit to stand. Should I consider a coccygyectomy? Well, I would say this, although obviously I can't advise in a specific instance, should this individual person be considering a coccygyectomy or not. That would be a conversation to have with your treating, clinicians. But I can tell you that in general, most people don't need coccygyectomy. but there are a few who do, and you know, so again, it's about 2 or 3% of my patients that I do end up referring for coccygyectomy in the instances where they've tried everything else and it has failed to give them adequate relief. So whether to have a coccygyectomy or not really depends upon, have you tried all of the other things first, and we can talk about some of those, everything from cushions and standing workstations and local injections and pelvic floor therapy, etc. One of the points you brought up, which was you have a lot of pain with getting up from a sitting position, and many patients with tailbone pain report that they have pain. Yes, it's painful while they're sitting, and again, I'll sort of show you here. It's a plastic model of the sacrum and coccyx. Looking from the back here, this is the sacrum up here, and then the coccyx or tailbone, is right down here. And when somebody is sitting, basically, if you're sitting, you are essentially, putting your body weight, onto, when you're sitting and leaning back, you're putting more of your body weight onto, the coccyx. And by comparison, I'm going to show you just on this one because it'll show the other sit bones a little better. If you're sitting, you can see how you're putting a lot of your body weight onto the other structures here, onto the other sit bones, these ischial bones, right? And then the tailbone, which is at the midline here, the tailbone, starts to engage more as you lean back. So a lot of times people with tailbone pain, they'll sit leaning towards one side or the other to offload the tailbone, or they'll sit leaning forwards because that offloads the tailbone. But when they sit leaning back, it's painful at the coccyx. But then what happens is that often one of the most common causes of tailbone pain is that the joints are unstable, that they are hypermobile, meaning that they move too much. So they go into a partial or even a complete dislocation while somebody is sitting and leaning back. And then when they go from that sitting to standing position, the tailbone snaps back into a different alignment, a more normal, typically, alignment. So many people with tailbone pain will report that, yes, it's painful while they're sitting, but during that transition from sitting to standing, the pain skyrockets. The pain goes up dramatically for those first couple of seconds, that they have to brace themselves. It almost takes their breath away to go from sitting to standing. That has been shown to be associated with hypermobility of the coccyx, which is diagnosed by doing sitting versus standing x-rays. This was something that was first pioneered decades ago by Dr. Maine, M-A-I-G-N-E, in Paris, France. And the sitting x-rays really are the way to diagnose hypermobility or instability, an unstable joint at the coccyx. And I'll keep grabbing just for this, just because I can show you an image of this. So we're talking here about, unstable joints at the coccyx. And what happens is that, hopefully this will focus okay for the video, but basically you can see, over here, people may have a coccyx that looks normal on an x-ray that's done while you're laying down or standing up, because while you're laying down or standing up, you're not putting any direct pressure or weight bearing onto the coccyx. But then when somebody goes into a weight bearing position, they may have a substantial dislocation that's only going to show up on the sitting x-rays and not on the other standing x-rays. So that's the dynamic instability or hypermobility or unstable joint. So I mentioned that just for the person who was asking the question about their pain, especially when going from sitting to standing. It would be very helpful if you're in a part of the world where you can get sitting versus standing x-rays done, if they know how to do them properly. That could be very helpful. The challenge there is that even though if this has been published for decades, most radiology centers are still not familiar with doing these sitting versus standing x-rays. Okay, let me just see another question here. Someone had their coccygyectomy about 3 months ago, still having a lot of pain at the end of the sacrum and the point where the incision is. Can't sit on a sofa yet. Sofas do tend to be difficult. Couches, sofas, things where you sink in, for many people is difficult. Is this normal healing? My surgeon was unable to smooth the arthritis edges of the sacrum as much as he wanted. because of proximity to the rectum. Yes, proximity, how close the coccyx is to the rectum, is a concern that many patients and surgeons do have when it comes to doing surgery for the tailbone, just because, of course, you do not want to injure the rectum during the surgery. But is it normal healing? I would say, obviously, for the person who's posting this, you should touch base with your surgeon. If you're having pain that you're not sure if that's abnormal or out of the ordinary, you should be touching base with the surgeon. I will say it is very common to have pain that persists after surgery. In fact, it's a relatively small percent, maybe 10-15% of people who after a coccygyectomy will have, a quote-unquote complete cure, meaning that they have no tailbone pain whatsoever anymore. Many people, unfortunately, will still have some persistent pain, although in the majority of cases it's better than it was prior to the surgery, but still some degree of persistent pain. There is scar tissue in the area and such. But 3 months out, it's not surprising to still be having pain. The biggest thing to be watching for and making sure is that the area after the surgery is not infected. The rate of infection is unfortunately very, very high after amputation of the coccyx removal, or coccygyectomy as the term is called. And the reason why the infection rate is so high is that the tailbone is very, very close to the anus. So the area where our stool or bowel movements exits the body when we go to the bathroom is really just a tiny distance away from the spot where the surgeon would need to do the surgery in order to remove the coccyx. So there's no way for you to keep that area quite as clean and sterile as you would if it was a surgery on your shoulder or wrist or foot or ankle or something like that. And you mentioned about the surgeon not being able to smooth down the edges at the time of the surgery. I have inherited patients who have undergone surgery where the surgery is done, and then afterwards the patient has an area where, I'll try to draw it out here if I can, where the patient has a bit of the coccyx remaining, and it's left in a pointed shard. I'm no artist, so this is sort of my attempt at that. If you're looking at the sacrum and coccyx, if whatever spot is cut by the surgeon, they need to do their best to smooth that out, because otherwise when you sit and lean back, you're going to be sitting on a pointy area. And I have inherited patients where if the sacrum up here is still intact, the lower part of the coccyx has been removed, but the part of the coccyx that's remaining is basically left in a way that's making this really pointy shard, so that every time you sit on that area, you're essentially sitting on a pointy area and pinching the skin beneath that area. So that can be very, very painful. There are things we can do for that non-surgically sometimes in terms of injections and things. And there are also times when, if that doesn't help, where somebody needs to go back and have additional surgery to remove or smooth down the pointy area. Okay, so next question here is, let's see. All right, so next question here is, have you seen better results with ganglion impar injections or pudendal nerve injections? So pudendal nerve injections in and of themselves do not tend to help much with the coccyx pain itself. The coccyx is not innervated by the pudendal nerve. So again, back to our anatomic model here, of the sacrum and coccyx. You can see there's nerves that exit, at each level along the way. The pudendal nerve comes off, from sacral nerves, sacral nerve levels, 2, 3, and 4, and the pudendal nerve, basically after it exits, from after those nerve fibers come off from the sacrum, they swing around to this little notch on the pelvis called the ischial spine, and they swing around there, and sometimes they can get irritated or inflamed there, and then the pudendal nerve swings down, to what's called Alcock's canal, which can be compressed there. And pudendal nerve problems typically will cause pain in the area of the external genitalia rather than pain at the coccyx. So some people do have both coccyx problems and pudendal nerve problems. But if somebody has an isolated coccyx problem, I would not expect the pudendal nerve injection really to help with that. Whereas a coccyx-specific injection, which can certainly include ganglion impar injections, that's certainly an area that I've published a lot on, those can be very helpful for coccyx pain. If you have both, by the way, pudendal nerve problems and ganglion and coccyx problems, rather, you can find, I do have, for a lot of these, I should mention, if you go to my website, which is tailbonedoctor.com/blog, B-L-O-G, and you'll see in the upper right-hand corner, there's a little search box, and if you put in pudendal, you can find information about that, or if we put in coccydyectomy, you'll find information about that, or if you want information about pelvic floor, or those kinds of things, you can find, or MRI, etc. You can find information and articles and links and videos that I have on those topics. Okay, next question here is my tailbone pain is from childbirth. That is, by the way, very, very common. That, as I mentioned earlier, as the child is passing through the birth canal, if I hold this properly to the camera, you can see certainly how the tailbone is basically blocking the way. So some women will have an actual fracture where even in the labor and delivery room, people can hear this sort of unpleasant kind of crackling, fracture sound, or women can have a dislocation, etc. Either during the labor and delivery, for example. Let's see. So basically, this person had tailbone pain from childbirth a year and a half ago, and she's saying that she had separation. And what happened to the coccyx? Have you seen this with women with SPD, which is symphysis pubis dysfunction? So basically, at the front of the pelvis are the pubic bones right here, and between the two pubic bones, there's this pubic symphysis, which is just means that the two of them come together. And SPD, or symphysis pubis dysfunction, just means sometimes people will have a dislocation, here. And one of the things that happens as women are getting closer towards the end of pregnancy and then going into labor and delivery is that the human body, releases hormones, one of which is called relaxin, that relaxes a lot of the ligaments because just humans, we are a species that has a tough time delivering this 9-ish month gestation infant through the birth canal, just as a function of the size of the baby and the shape of the pelvis to allow us to be upright and ambulatory walking. So at any rate, the relaxin helps to relax some of these joints. So the pubic symphysis, the pubic joint, you could call it, up in front, the sacroiliac joints in the back, here and here, the coccyx joints here, and relaxing those is a good thing because it allows the child to pass through the birth canal. However, as with all things, sometimes things can be too much, and if there's too much relaxation and there's too much movement, people can have dislocation of the at the pubic symphysis. They can have dislocation at the coccyx. Certainly, lots of pregnant women and new moms will have sacroiliac joint pain, pubic pain, coccyx pain. So all of those things can happen. And to this person who's asking the question, can separation cause the tailbone to break or be in the wrong spot? Unfortunately, yes. There can be fractures and dislocations, and especially that instability that we mentioned earlier. That basically, let me go back to that image, if I can hold it up here, where the tailbone goes from having this normal alignment to being dislocated. And again, the way to test for that typically is to have X-rays done in the sitting position. But there's all kinds of other pain syndromes that can occur. Again, I don't know how well this will focus, but this talks about, pain at the facet joints and sacroiliac joints and piriformis muscles and ischial and pain down into the leg, kind of a sciatica, type of picture. And again, the tests that are done are the sitting x-rays, the x-rays that are done while the person is sitting, because that's the position, that they are weight bearing. Okay, so let me move on and see the next question here. I've been in pain for over 6 months. MRI came back clear. Pain starts every morning after a bowel movement. I've had a cortisone, which is a kind of steroid injection, and says that they have MUA, which is manipulation under anesthesia. I use a cushion. Is there something moving down there? There may be something moving down there. Again, the test for that would be the sitting versus standing x-rays to see if there is that hypermobility, that excessive movement at the coccyx. Back to your point that you had an MRI that came back clear. I have a number of videos and articles on this. The key is 2 things. Number 1, did they do the MRI properly in the first place? Did it actually include the coccyx or tailbone? So problems at the tailbone or coccyx, down here, are 10 to 20,000 times less common than problems up at the lumbar spine, right? So almost all humans will have some episodes of low back pain, up by the belt line or waistline. However, most, will never have a significant or long-lasting episode of coccyx pain. So a lot of times radiology centers are on autopilot, and even treating physicians, pain management doctors, orthopedic doctors, primary care physicians. You go in and you say, hey doc, I've got some pain down there. A lot of times they never even look at the tailbone. They never even palpate or press along the tailbone to confirm where the pain is coming from. They just check off a box that says low back, x-rays or MRI, which really comes as lumbar or lumbosacral x-rays, which basically is lumbar spine and does not go down low enough to include the coccyx. So when somebody tells me that their MRI was clear or their MRI was normal, I have a healthy dose of skepticism, just because, having been in practice for, roughly 25 years now, and more than 20 of that, treating patients with coccyx pain. I have times when patients fly in to see me and they show up with a stack of CDs and they say, yep, I've had 2 MRIs and I've had a CT scan and I've had x-rays, and we go through the whole stack and there's not a single image in there that includes the coccyx. Because everything was focused on the lumbar spine. It is absolutely insane. It is crazy. It sounds ridiculous. But I basically, one of the rules of thumb I tell people is ask your physician to point to the tailbone on the imaging studies. And that one little piece of advice, which sounds so simple, right? Patients will, I get these emails from patients around the world, people around the world, who will say, holy cow, my orthopedic doc, who I've been, I asked him to show me the tailbone on the MRI that was reportedly normal 2 years ago. And when my orthopedic doc or pain management doc, pulled up the images to show me, because I pestered, him long enough about it, he went to point and he's like, wait, the tailbone's not even on here. So again, it's very common. You really just need to get a copy of the radiology report. Take a look for yourself. Does the radiology report, does the radiologist actually even mention the tailbone in their reading of of how things looked? All right, someone else says sitting on a hard chair is fine. So this is a good point, and we mentioned a little earlier, which is, sitting on a hard chair allows you. Let me see if I have. When you sit on a hard chair, one of the things that you can do is you can start to put some of your body weight, onto those other sit bones, as shown here, and you can see that the tailbone is not touching the chair. Alternatively, if you go to sit, I'll just grab if you go to sit on something soft like the couch, now what happens is that those sit bones sink down, and the coccyx, starts to make contact with the sitting surface. So although it's not true for everyone with tailbone pain, it is very, very common that people will say, that their pain is actually worse when they're sitting on a soft surface. And that sounds counterintuitive, right? You think of a soft chair as being, the comfy chair for most people, but for people with tailbone pain, that's often not the case. One of the recommendations on beginning to sit after tailbone removal, currently a week and a half post-operative. So someone who had their tailbone amputated or removed a week and a half ago. First and foremost, of course, I would tell you, be in conversation and follow the recommendations of the actual treating surgeon, right? So I'm not going to overrule, him or her because, if I don't, know you personally, etc. However, I will say that in general, a lot of doctors will recommend, that people resume sitting 6 to 8 weeks after surgery because that area does need time to heal, right? There's a cut edge of the bone there. The skin is raw. It's common to get infection and skin breakdown, and for the skin to heal, it needs oxygen and nutrition, which it gets through blood flow. If you're sitting on that area and putting your body weight, just like if I push my fingers together, they'll start to blanch, and you can see how it got pale, for a moment just from a couple of seconds, and now the pinkness is coming back. Similarly, now imagine if that was a surgical site and I'm sitting on the surgical site and I'm blanching the skin, meaning I'm pushing all of the blood supply out of it so that the skin is pale and it's lacking the oxygen and nutrition and protein and everything it needs in order to heal that tissue. So that's the reason why sitting is discouraged initially after tailbone removal. How soon to get back to it? I know that there's one website that says people can go back to sitting and back to work within a day or two after surgery. I certainly don't I don't think that's realistic in the vast majority of cases. I think that probably more like 6 to 8 weeks is more common. So really, then after surgery, there is that substantial chunk of time where you're eating your meals standing up at the kitchen counter. You are, if you're watching television, you're either watching standing up or you're watching laying sideways on your couch, or you're, if you're on your laptop or your iPhone, you're laying down, face down, kind of like laying on your chest, with your device in front of you. All right, let's see other things. What is a type 1 coccyx? So basically, what this person is referring to is there are different there's different anatomy at the coccyx in terms of the appearance at the tailbone. So years ago, this was categorized into 4 different types in terms of what is the angle. Let me find my model here. So basically sacrum and coccyx. You can see when you look from the side view here how there's this kind of gradual forward curve, from the sacrum and down through the coccyx. But that curve can be very variable. So with a type 1 coccyx, the tailbone is curved just a little bit forward, kind of like the way it is actually on this model. With a type 2, it's curved further forward. With type 3, it's kind of angling straight forward. So point being, there's variability in terms of the appearance or the angle of the tailbone, and that can be relevant in a number of ways. The further forward forward facing or forward flexed or forward angled the coccyx is, the more that it's tucking into the pelvis. Which in some ways may be good, because if it's sticking backwards out of the pelvis, it's going to hit the chair sooner when you go to sit and lean back. But if it's tucking into the pelvis, that can cause other problems, like it can be basically pushing forward into the rectum, which can have pain with bowel movements and things of that nature. So that's answering your question about different type 1, 2, 3, 4, etc. of the coccyx. Let's see. The next person says, my last ganglion impar injection, which is a sympathetic nerve block, the sympathetic nervous system, which is the fight or flight response we learn about, the sympathetic nervous system. If a lion or a saber-toothed tiger came walking into the room here right now, I would have a sympathetic nervous system response, meaning my blood pressure would go up, more blood would start to rush to my heart and to my muscles, and I would start breathing faster, my pupils would dilate, and then there's going to be this fight or flight where I'm either going to fight off that threat or flight, meaning I'm going to run away. So that sympathetic nervous system is hardwired throughout our body, and there's a particular hub or cluster of those nerves, which is called a ganglion, which is right at the level of the coccyx. And often that fight or flight response can, that nervous system can be aggravated and irritated at the level of the coccyx. So putting local medication there, which is as a sympathetic nerve block, can be helpful. So this person is saying that they had such a block and they were essentially pain-free for about 18 months, so a year and a half. So a year and a half of relief after it's really a 5-10 minute injection. I do hundreds and hundreds of these per year. That's a solid stretch of relief that can give great quality of life for an extended period. And then the same person is asking, did I just get lucky with my response that one time, or can I get that relief every time? So I would say it is common that people will get good relief from an injection. What's most important and what's most predictive, though, is that the injection needs to be individualized for the specific patient. And the reason I say that is that I inherit a lot of patients where they've had injections done that did not give them any relief, and they're convinced they must need surgery. But then I'll find out that the injections, they were either done blind, meaning that they did not use fluoroscopic guidance to target the specific spot, or they only used ultrasound, which gives a very limited view at the coccyx, or the physician did not have the sitting versus standing x-rays done in advance, so the physician had no idea what joint was abnormal, or their MRI didn't include the coccyx, so again, they did not know what the abnormality was. Or I'm just grabbing here, just to show again, as an example, if somebody has a bone spur, which in Europe a lot of the doctors refer to that as a bone spicule, but basically it's as shown here. All right, hopefully you can see that image, which is where there's a little extra bone down at the bottom of the I have another image here that'll show it. A little bit of extra bone down at the bottom of the tailbone. And when that's the case, and this typically, the bottom of the tailbone is very poorly seen on most x-rays, you need to do what's called a collimated view, which is where we take this metal cylinder. It looks almost like a zoom lens, or like a metal Pringles can, a cylinder. And that zooms in on just the coccyx, which therefore decreases the radiation to the pelvis that you otherwise would get if you blanketed the whole area. But also it gives you a much cleaner, crisper, more detailed image at the coccyx, so that even down at the lower part of the coccyx, where the coccyx gets very thin and slender, that we can see if there's a bone spur there. And the bone spur can cause problems because normally if you're sitting, I describe it as being, when you're sitting, that the sacrum and coccyx, as I showed before here, having that curve to them, is almost like the curve of a rocking chair. So if I was doing sit-ups, I'd be rocking back and forth on the sacrum and coccyx. But now if you have a bone spur, it would be kind of like if you had a rocking chair with a piece, pointing down, like this. And now when you sit and lean back, you're going to be pinching on that spot. And the reason why it's relevant in answering, this particular question about what response you get from injections and is it just luck, if the doctor has not made a specific diagnosis as to what part of the coccyx your pain is coming from, whether it's an unstable joint or not, whether there's a bone spur or not, those two things in combination make up probably 80% or more of all of the causes of tailbone pain out of a few thousand patients that I've seen for coccyx pain. So if your doctor isn't screening for those and then isn't doing the injection at those spots, the doctor may be doing an injection. Let me just grab a pen here so I can point this out. So again, here's the coccyx. The doctor may be doing an injection here at the sacrococcygeal joint when really the problem was down at the spur, down at the bottom. So again, now side view of the same thing. If the injection is up here, but the problem was down there, then it's sort of a hit or miss, or that the doctor may not be able to get the kind of relief that you want. All right, next question here. How do you tell if it's a pilonidal cyst? Great question. In fact, in my YouTube videos about coccyx pain, I made a video about coccyx pain and how to distinguish that from a pilonidal cyst on YouTube. If you just my YouTube channel is called Tailbone Pain Doctor. My website is called tailbonedoctor.com. Ironically, even though I do not treat pilonidal cysts, one of the videos that actually has the most thousands of views out of anything I've put up there is one about pilonidal cysts, even though I don't treat pilonidal cysts. But I was distinguishing how to distinguish it from from tailbone pain. The best place I can tell you to go, I have a couple of articles on this on my website. So for that, if you go to tailbonedoctor.com/blog, and then basically on there, you can put in the word pilonidal, and it will give you a couple of articles and a video that I have specifically on distinguishing the coccyx pain from a pilonidal cyst pain. The same person says now they're suspecting osteomyelitis of the coccyx. So osteomyelitis, osteo refers to bone. Myelitis is inflammation, and specifically for osteomyelitis, it's an infection of the bone. Infection of the bone is very, very serious, right? So infection of the skin, which is like cellulitis, like if I scraped my arm while I was, working in my yard, on the hedges this weekend or something, that's serious enough, but not the end of the world. That can be treated typically with oral, meaning by mouth antibiotics. But if it's an infection of the bone, then medication, antibiotics by mouth usually are not enough to get a good enough dose down deep into the bone. So typically people for osteomyelitis will need to be on intravenous antibiotics, meaning that you have to have an IV line in, and they can put in a certain type of central line because you often need to be on those intravenous antibiotics for about 6 weeks if it is a bone infection, is typical. So again, talk to your treating physicians if they think it's osteomyelitis. I do have some materials online about osteomyelitis and how to look for that. So I would again refer you to. I'm just looking to see if I can pull it up here. Yeah, I do. If you look at if you go to tailbonedoctor.com/blog. Then this will talk about that, and I'm actually going to grab one of those links right now, and I'll post it in response to your question here if I can. All right, so let me come back to and the questioner asked about with osteomyelitis and a sinus tract, which is a tunnel. A little, there's often discharge. So all of those things are important. All right, here's someone who lives in Northwest England. So greetings to Northwest England. I have relatives there, not far outside of Manchester in Warrington area. So greetings to you out there. Let's see, the injured coccyx 20 years ago, initial healing, physical therapy, or physiotherapy as it's often called outside of the United States. I was pain-free until my last pregnancy, had the pubic symphysis dysfunction that we talked about earlier. Manipulation under anesthesia was unsuccessful. Let me take a moment to talk about manipulation under anesthesia. Basically, manipulation means that the physician tries to aggressively move or hypermobilize the tailbone. And manipulation under anesthesia can be helpful for some conditions, and in rare cases it might even be helpful for the coccyx. But the most common cause of tailbone pain is that joint hypermobility or instability that we talked about. So that issue that we discussed, where the tailbone goes into a dislocated position already when you're sitting. So if you have a joint that's already unstable, and now you have a physician who puts you under anesthesia so your muscles relax, and then he or she tries to hypermobilize that further, there is the potential to make that worse. And unfortunately, I've seen patients that have been had worsening from that. So you really want to make sure that before you undergo manipulation under anesthesia, that the physician has done the sitting versus standing x-rays to rule out whether you may have that hypermobility, because that may be a relative contraindication, a point against doing manipulation under anesthesia in the first place. And this says the coccyx was fused in one position with no movement. If your coccyx is fused, which again, the proper imaging studies would show if it's actually fused into a solid single bone, in most cases it is not, but it can be, then you're not going to be able to manipulate that. It's going to be a solid, if it's a solid piece of bone, then whether you're under anesthesia or not, manipulation is not going to move that. The only way to move it, which you shouldn't in this case, would be to actually fracture it to try to move it. So, and I certainly am not recommending that. So let's see, and then had a steroid injection that helped every 6 months, and then the relief got less long lasting, and now you're waiting for full removal. Again, hopefully, again, I don't know the details of your specifics, but hopefully they've done it. They've done the testing to try to find the actual cause, and to be able to look for what's causing this in the first place, because that becomes important. And you mentioned full removal. One of the questions I had in advance was about partial removal versus complete removal. Is partial just as good? It sort of depends. There's one study that showed that people did better when they had a complete removal rather than a partial removal. What's in my opinion most important is that prior to the surgery, prior to any treatment really, that the physician has done their best to find what is the specific abnormality at the coccyx, what specific part of the coccyx, what specific location, and what is abnormal that's happening there. Is it an unstable joint? Is it arthritis at a joint? Is it a bone spur? So I have inherited patients where, let's say, again, back to our anatomic model here. And this, the way it shows up to me, by the way, on the Facebook Live, it's all as like a mirror image. So every time I think I'm moving my finger or the model to the right, it goes to the left. So if you see me sort of looking disoriented, you'll know why. But at any rate, the sacrum up here, the coccyx down here. I've had patients where, let's say that their abnormality is here at the top of the coccyx, at the sacrococcygeal joint. They have terrible arthritis and an unstable joint, and then the surgeon may come along and remove the tailbone, but only remove the lower half, and leaving in place the actual joint that is the abnormality that's causing the patient's pain, right? And again, that sounds crazy, but unfortunately, for many doctors, the tailbone is sort of like this black box. They talk about it as just like, oh, well, it's coccydynia, which is just a medical term that means tailbone pain, right? It would be like saying, okay, I have chest pain. Okay, well, if I have chest pain, we would know that it would be important to find out, is that coming from my heart, right? Is it a heart attack? Is it coming from a pulled muscle? Is it a fractured rib? Is it indigestion because of something I ate, right? Because the treatment for all of those would be vastly different. So it's very important that people try to get a specific diagnosis so that you can individualize the treatment. One of the most common questions I get, I lecture a lot on coccyx pain at national and international conferences. And one of the questions I sometimes get from other physicians is, what's the best injection to do for coccyx pain? I know you publish on this area a lot, Dr. Foye. What's the best injection? And it is a crazy question. And I compare that question to me going into my automobile mechanic and saying, Joe, what's the best thing to fix when somebody comes in with a car problem? Right? The mechanic would immediately know that I know absolutely nothing about cars, right? Because what's the best thing to fix for my car problem? Well, what's the problem, right? Is it, is it that it won't start? Is it that, there's a squeak? Is it that, the brakes don't work or the tire is flat? Like, what's the best thing to fix is going to depend upon what was the problem in the first place. So the question itself, when doctors ask me that, tells me that there's a good opportunity for me to do some physician education. All right, so the next question here is, after removal, will steroid injections help? So I have many people who I treat for tailbone pain who have already undergone coccygyectomy or surgical amputation or removal of the tailbone. So yes, there is treatment after coccygyectomy. Unfortunately, although there's again that 10 or 15% of folks who have complete 100% relief after coccygyectomy, much more common is that people are doing better, but that they're not 100% out of the woods. And then, unfortunately, there's a small, but concerning population that actually feel worse after the surgery. No one specific treatment is perfect, as you know. But at any rate, the patients who have persistent pain despite coccygyectomy, they often come to me. The first thing we do before any injections is to try to figure out why are they still having the pain, right? So we do screening by questions and sometimes by blood work and by imaging studies. First of all, is there an infection at the surgical site, right? Osteomyelitis, as we talked about earlier in this video, for example. Is there a retained piece of bone, a bone fragment that's still present at the site that is, the source of pain, which we talked about? Or did they shave down the end of the bone in a way that left a really, pointy, sort of stabbing type of area, where they took off the the lower part of the coccyx here, but that when they left the bone, they left it really sharp, jagged edge. So we look for is there an identifiable cause, and often there is, but sometimes there's not. And then yes, there are times when there can be a lot of inflammation at the site, and putting a local anti-inflammatory there can help, or doing certain types of nerve blocks there can help. So all of those things can be helpful components, depending on the specifics of a given patient. One other thing is that sometimes people will have prolapse, which is one of the questions I had. That was a question that came in advance, was about prolapse or sagging of the pelvic floor, because many of the pelvic floor muscles and tendons and ligaments have attachments to the coccyx. If the coccyx is gone, now there is some weakness of that pelvic floor. And prolapse means sagging or drooping. So the pelvic floor can start to sag or droop, and that can change things like your ability and control over bowel movements, for passing your stool when you go to the bathroom, or even can affect your bladder for eliminating or getting rid of your urine. So those can be other issues sometimes after surgery as well. So we have to look for all of that, of course. Next question: what are some good oral analgesics, so pain medications by mouth, for tailbone pain? We talked about this a little earlier, where there's the anti-inflammatory medications. Can be helpful sometimes for short-term use, as long as you don't have contraindications like history of bleeding ulcers in your stomach, or kidney problems, or a history of stroke or heart attack, or those things, because your oral nonsteroidals, ibuprofen, Advil, etc., can cause naproxen, naproxen, etc., can cause issues with those. Acetaminophen or paracetamol, Tylenol, sometimes can be helpful, but those are mostly for short-term use. Sometimes people will have a lot of nerve pain in the area, and sometimes things like gabapentin, which is trade name Neurontin, or pregabalin, Lyrica, or Cymbalta. Some of those medications for nerve pain may help. So there's a variety of things that can be helpful. Is it common for tailbone pain to be caused from simply sitting too long or too much? Sitting is a problem in our society, and some people have talked about that sitting is the new smoking in terms of risks to your overall health, meaning that in sort of modern, Western industrialized societies, we sit a lot. We sit because we're on our computers a lot of the day. We sit, and of course we sit, when we're having our meals, or we sit if we're watching TV. All of those things mean that you're spending a lot of time, on your butt, in the chair, putting pressure onto the tailbone. And that's part of why tailbone problems can be such a substantial disability for patients, because so much of what we do is sitting. If you're commuting to and from work, you're driving back and forth, you're on a plane going to see some relatives or a business meeting, all of those things can be problematic. So sitting for a long time in and of itself is probably not taking a normal symptom-free thing and making it symptomatic. But if you have some underlying arthritis or a bone spur or instability, the more you sit on it, the more it's going to flare that up. So some things you can do, the cushions can be helpful. Again, the donut cushions typically are better, for many people are better than the wedge cushions. So we're talking about, cushions for tailbone pain. And, and basically the donut cushions is the higher one shown here, which is basically a ring with a hole in the middle of it. The wedge cushion is shown down here, kind of has a cutout in the back so that when you sit, you're no longer putting your body weight onto the tailbone, that the tailbone is sort of hovering above that. Standing workstations can be helpful because, while you're standing at your workstation, you can move around. You're not sitting in one spot the whole time. Many people find that it makes us more, alert and, and sort of efficient as we're doing our work. But there's limitations on that too, right? Because if you're standing for 8 or 10 hours a day, that can be a problem if you have, arthritis in your knees or problems at your feet, or poor circulation and varicose veins in your legs, or if you have low back pain or sacroiliac pain. So, so everything comes, as in most things in life, there's a balance. The next question here is a great one. Is it possible to develop coccydynia from an L5 central disc herniation? I would say it is possible, but it is unlikely, meaning that the idea that here's what happens most typically, right? So it's not impossible, but I would say probably 1,000 times to 1, right? It's dramatic. It's dramatically more likely that the tailbone pain is coming from the tailbone, right? So maybe 1 out of every 1,000 or 2,000 patients who I see for tailbone pain will actually be coming from someplace higher up, like the lumbar spine. What happens, unfortunately, is what I was mentioning before, which is physicians and radiology centers are on autopilot for the lumbar spine because that is 10 or 20,000 times more common than tailbone pain. So they got the x-rays and the MRI of the lumbar spine, and it happens to show a disc herniation, which here at the lumbar spine, this is a bone, a vertebral body, and then the disc, and then the next bone, and then the disc, and then the next bone. And the disc is like a shock absorber. And sometimes a disc can bulge or herniate out of its normal place, almost like squeezing some of the jelly out of a jelly donut. So someone may have tailbone pain, and I've seen hundreds and hundreds of patients where this has happened. Someone has tailbone pain, they see their local doc, they check off the box to get some x-rays or MRI. The MRI is done, but it's of the lumbar spine. It never even includes the coccyx. It shows a lumbar disc herniation, which maybe is causing 0 symptoms at all. It may be totally asymptomatic. It may be something old from a disc herniation, 4 or 5 years ago. But the doctors see that and they say, oh, well, let me do a lumbar epidural for that. Let me do an lumbar epidural steroid injection. And if that doesn't help, let me do a lumbar surgery to remove the disc and fuse the spine. And I've had patients who, unfortunately, they wake up from surgery, just having had their lumbar spine surgery, and they say, holy cow, as soon as the anesthesia wore off and I kind of came to, became awake and alert again, I said, I'm still having that exact same pain down at the lower tip of my spine. So I would be cautious about that. Similarly, I've had patients who have had a pelvic MRI that was done that showed a fibroid uterus or endometriosis, and somebody reacts to that by actually doing a hysterectomy to remove the uterus on the patient. And I've had, unfortunately, multiple patients that I've inherited where that was, their story. And they say, so now I have no uterus, and I still have the same tailbone problem that I had before, and I just had an unnecessary surgery. So you always want to put in context, is the, when you see something on an MRI, for example, is it an incidental finding, or does it actually correlate with where the patient is having their symptoms and where their physical exam findings confirm that they are tender to the touch? All right. Next person here is asking about SPD. So again, that pubic symphysis, dysfunction, at the front of the pelvis here. Getting a lot of questions about that today. And seems to have flared up my pain 9 years ago. I had a C-section. I really believe it's linked to the SPD. Absolutely, the whole pelvis, the whole pelvis does work as a unit, to some extent. So kind of there was sort of a nursery rhyme or something we learned as kids, like the shin bones connected to the thigh bones, connected to the to the hip bone or the pelvis, like all of the many of these things biomechanically are related. So absolutely, it can be true that something being off in one area can change how much pain you have in another area. With the tailbone, in fact, it's very, very common that people will have, and I'm just looking down to grab another page on here. It can be very common that people will have pain that starts at the tailbone, but then because they have pain at the tailbone, they cannot sit in a normal neutral way, right? So they will start to sit leaning towards one side, leaning to the other side, leaning forwards, and all of those things put an abnormal, non-symmetrical, left versus right difference amount of pressure onto the sacroiliac joints and the pubic bone, pubic symphysis up in the front, and the hip joints, and the ischial bursa and the piriformis muscle. So so people will start to get pain not just at the coccyx, but they'll get all of this back and buttock pain as well. So basically you can see that there'll be all of these do it here. All of these other areas that are affected, the facet joints, sacroiliac, piriformis, etc., that we've talked about, pain even going down the leg. So so it's important to look for all of those, and yes, they can be related. By the way, for those of you who have joined more recently, if you go to Amazon today, you can grab the book for free. Anywhere in the world, the electronic version of the book should be free today. You just have to, when you go to Amazon, if you search for the word tailbone and my last name, which is Foye, F-O-Y-E, you'll find the book there. You just have to click on, when it says see all versions or editions, click on that button, because then it'll show you the electronic version, which is the version that's free, all day today, and partly into tomorrow. So if you see this on Sunday or Monday, give it a try. Definitely it'll be free today, though, Sunday, November 15th. If you're not seeing this until Monday, the 16th, give it a try, and it may or may not be. All right, the next person is asking, is a rolling stool brought in sufficient for sit-stand x-rays, or should a piece of wood be placed on top of the stool to elevate? Also, should the patient lean back sitting in a, slightly in the sitting position? So these are great questions about how to do the sitting versus standing x-rays. First of all, be careful with a rolling stool, because I've inherited a lot of patients who have actually fallen off rolling stools and rolling chairs, and that has been the cause of their tailbone pain in the first place. So that's number one. Number two, when the sitting x-rays are done, you don't want there to be too much cushioning or padding, because number one, that can obstruct the view. Because if the tailbone, let me go back to sort of my example here. If the tailbone has, if this is sort of the padding for the chair that you're sitting on, if the tailbone has sunk down into it, then it can be, number one, it can be tougher to see the tailbone on the x-rays, and number two, the tailbone might not be bearing as much weight as if you would actually, put the patient onto a firm, hard surface. So that would be the issue there. So probably something harder in general will be better. Technically, it is a little challenging to do the X-rays, I will say. We've been doing them for about, I'm going to say about 20 years here at the Coccyx Pain Center here in New Jersey. I'm at Rutgers, New Jersey Medical School, and I've trained the radiology technicians how to do those. But it definitely was an uphill battle at first to get the technicians all trained and able to do those. So you may face some challenges depending on what part of the country you are in, or what part of the world. And also, have they ever heard of those X-rays in the first place? They'll often tell you there is no such thing, which is crazy because obviously, we do them, year in and year out, as does, of course, Dr. Main in Paris, France, where he invented them. Okay, let's see. This person is nearly 3 years out from a hysterectomy, so removal of the uterus. Over 2 years of pain, pelvic obliquity. Chiropractors cannot get my pelvis to stay level. I've referred the pain to my extremities and back. I'm on my second pelvic floor physical therapy. Pudendal nerve only lasted 2 days. Would a ganglion impar injection be more successful? So again, this depends upon specifically where is the pain coming from. Again, if you go to tailbonedoctor.com/blog, B-L-O-G, and put in the search bar, put in Pudendal, you can get information about that. You can also put in, if you put in impar, I-M-P-A-R, it'll give information about that as well. But basically, pudendal nerve injections do not tend to be helpful for tailbone pain, but they can be helpful for other pelvic floor pain syndromes. So that's that component. So again, would an impar injection be helpful? It depends. Where is your pain coming from? Certainly it can be helpful for a number of pelvic floor pain syndromes, including specifically problems at the coccyx, but for some of the other muscular pains as well. All right, next person here, next question. Oh, they're answering someone else saying they're sorry they're suffering with the pain. All right, are you doing telemedicine? Yes, I am doing telemedicine. So right now we are in the midst of kind of what this second wave, here in New Jersey of the coronavirus pandemic. In terms of the numbers are ramping up again, unfortunately. I'm just outside of New York City is where my practice is. New Jersey, unfortunately, had the highest fatality rates per capita of any state in the country so far. So we were hit very, very hard back in April or so, so March, April, May. And then things have been quieted down, and things now, unfortunately, the last couple of weeks are ramping back up again. So we are doing telemedicine. So many people have found that to be very helpful. It's actually, I describe it as one of the few silver linings that has come out of the pandemic, is that it has, made telemedicine visits much more accessible and accepted. And there's many patients where telemedicine, we can hear about what kind of symptoms they've been having, what things have been tried, what things have been done, and we can get a sense of where we should go next, both during the pandemic and also what would be the next steps when things quiet down and people are able to get out and about more. The nice thing, of course, about telemedicine visits, they're also called video physician visits or e-health visits or telehealth visits, is that they can be done from the comfort and safety of the patient's own home. So without going out and traveling, and normally, sort of before all of this started earlier this year, most of my patients come from outside of New Jersey. About 35% of my patients fly in to see me from around the country and occasionally internationally. Of course, with the situation being the way it is currently, flying, and traveling long distances presents a lot of challenges, during the current health crisis. So having the ability to do telemedicine visits in the meantime can be a very effective way of using this as an opportunity to get the legwork done in terms of figuring out what's causing the pain and all of that. So yes, that can be done. Right now that's done mainly for people who are here with me in the United States. I'm not sure, because I don't know for the person posting this question, I'm not sure where they are based out of in terms of international or not. And I'm not sure how the international would or wouldn't work. Let's see, next person says, thank you for all you do for our community, for tailbone pain sufferers. You are very, very welcome. Actually, it's on a personal note. It's professionally the most gratifying thing that I do in terms of patient care. In that there's a whole population of patients who unfortunately cannot find answers, and the doctors aren't particularly experienced in this area. So it's really gratifying to be able to make a positive difference for patients, to give answers when they haven't been able to find that before, to give relief when people haven't been able to get that before. So thank you for your comment, and I'm happy to help. As far as the community online, I've actually been off social media for about the last 8 months, so from March to November. So the reason I haven't been putting educational content on Facebook and Twitter is just I haven't really been on social media. I didn't even have Facebook on my phone until I just put it back on, within the last couple of days here, specifically for Tailbone Pain Awareness Day, has sort of brought me out of social media retirement, I guess. But I'm happy to help in any way I can. I'm very fortunate to be in a situation where lots and lots of people have helped me and my family over the years with not with tailbone pain, but with other issues. I've had times where my car is stuck in a snowbank and a stranger literally pulls over and gets out of his car and climbs into the snow to push me out, right? And I've had people who've done things for my son so anyway, so I'm happy to offer help in this domain where I can. Next question is, why do we get pain that comes and goes right down to the left, right or left of the coccyx, and the buttock? This may vary. So again, sometimes what can happen is that the pain, can be not only at the coccyx, but sometimes there can be spasm within those pelvic floor muscles that attach to the coccyx. So those may be part of the issue. When somebody's talking to the right or the left of the coccyx, sometimes they're talking about, the sacrospinous ligament, which goes from the sacrum and the coccyx over here to the ischial spine. So it sort of spans the area where, my fingers are showing, spanning now. Sometimes it's the piriformis muscle. Sometimes it's the ischial bursa down at the bottom. Sometimes it's the obturator internus or obturator bursa. So there's a number of different areas. And ideally, if you're seeing a physician or pelvic floor therapist, someone who's familiar, that is specifically familiar with evaluating and treating this area, they can usually help to hone in on which of these areas seems to be causing the pain. Let's see. Next question. Do you think getting injections for the rest of my life is okay as long as they keep working? So yes and no. So it sort of depends here. If somebody is able to get an injection that takes 5 or 10 minutes to do that, and they're getting lots of relief and good quality of life for a good stretch of time, so many of our patients, for example, will have 90 to 100% relief, and then but the pain may come back in 10 months, a year, 2 years, 3 years, 4 years, or hey, the pain didn't come back until 7 years later and I had a slip and fall on the ice and it flared things back up. Then in a lot of those situations, we would say, okay, well, terrific. We have found a treatment that is effective for you, that's helpful, that gives good quality of life, that helps you to avoid undergoing the surgery. So if that's sort of the best that medicine has to offer for the time being, that's pretty good, and that can be continued. On the other hand, if it was, hey, the injections only give me partial relief and it only lasts for a month, then certainly I would not be recommending that somebody be getting, an injection at their coccyx 12 times a year. Not so much because it's going to cause problems there, but it's just not practical. It's just not, that helpful of a treatment. So you would be sort of looking to climb up, sort of the next step. In my practice, we often talk about sort of, a treatment ladder, meaning, we start at the bottom and we work our way up with simple things first, like avoiding exacerbating factors and using the cushions and then some short-term use of medications and making a diagnosis and different types of injections and surgery is sort of up near the top of that ladder. And then there's the treatment that we do after the surgery for the patients who unfortunately have persistent pain that continues. Next question here is about complete versus partial removal of the coccyx during coccygyectomy. that question, it looks like this question was posted 45 minutes ago, and I think I answered it since then. So I'll refer you back to that part, and I can actually post in here. I'll post a comment, just giving that that information again. But the main thing is, did they remove the site that was abnormal, and did they smooth off or shave down, the remaining edge? Those would be some of the issues that are critical. The United Kingdom doesn't do the x-ray of the coccyx, let alone sitting versus standing. That is a very common misconception. I have actually, if you go to my website, this can be very helpful for those of you in the United Kingdom. If you go to tailbonedoctor.com/blog, B-L-O-G, and just put in United Kingdom or UK, I have a couple of articles that I've written specifically. What I've done is to screen capture and quote the United Kingdom, the National Health Service criteria for getting x-rays at the coccyx, and specifically for getting sitting x-rays at the coccyx. So that certainly can be done, and I encourage you to go to my website, and you can actually print that page, and you can print the information, literally the official NHS information that your own local doctor probably has never looked that far or that deeply into the issue. So it's a great opportunity for you to do, instead of patient education, you'll be doing some physician education. There's another question here about pilonidal cyst and osteomyelitis. I think I already answered this one. I think maybe it's just a copy paste because I hadn't gotten to it yet. Okay, so another question here then is, after removal, pain of the coccyx, after coccygyectomy, coccyx is not gone, what can help? Again, number one is finding out, why is there pain still there? Is there a large fluid collection? Is there a pelvic floor prolapse? Is there a rectal prolapse? Is there a retained bone fragment? Is there an infection? Is there a sharp pointy area? Is there heterotopic ossification, which is this condition where bone, excessive bone starts to form? So there's lots of abnormalities that I've seen after coccygyectomy that can explain why the pain is persisting. And sometimes, though, we don't have a specific reason. It's just the scar tissue and irritation of the nerves at the surgical site. And the things that can help are cushions and sometimes pelvic floor physical therapy to work on the scar tissue, and local injections can help. And in a small minority of cases, there's some patients who do require repeat surgery, depending what we see. Next person is asking, are the injections themselves painful? I would say the vast majority of patients tolerate the injections very, very well. For example, we do not need to put people under anesthesia, or intravenous sedation for coccyx injections. The coccyx is very, very close to the skin. So as long as you have a physician who is experienced at doing the coccyx injections, it should not be a particularly painful condition or injection. There are spots where just as I first put some local anesthetic at the skin, the patient will certainly feel a pinch then, and then they may feel some fullness as the local anesthetic goes in. It may tingle, and then it will start to numb up so that it's numb for the injection itself. The needles, for example, that I use for the coccyx injections, they are the thinnest and shortest of any of the spinal needles that we have in our entire fluoroscopy room in our pain management suite. So unlike for those of you who have had epidural injections, and I do epidural injections in my practice as well, those are longer needles. They are thicker diameter needles compared to the ones we use for the coccyx. How can we get a diagnosis without the correct x-rays, especially during this time with our inability to travel to New Jersey? So I would say things that can be done even while you can't travel. There are absolutely lots of instances over these last months where people have no diagnosis and they have set up a telemedicine visit with me. We review with them what imaging studies have been done, and then I can tell them which of those imaging studies it makes sense to contact the radiology center and get a copy of the CD and send it to me. And it's actually not uncommon at all that we're able to find abnormalities on the imaging that has already been done, that just was missed by the radiologist or the treating physicians. So that would be one option that certainly can be helpful for many people in the meantime. Let's see. Here's somebody saying, should I go for coccygyectomy? of course, I can't tell you whether you should or shouldn't have a specific treatment, but just the person is, because you and your treating doctor will decide that. But saying I've had 2 blind steroid injections and prolotherapy. So basically, the issue about the blind injections again is you don't know. I've treated thousands of patients with coccyx pain. I've done thousands of coccyx injections. So I know the anatomy very, very well. But to target a specific joint where a specific abnormality is would be very challenging doing that blind. It would be very challenging doing that without the guidance of fluoroscopy. So along those lines, the fact that you've had blind injections that did not work, and now your doctor is saying, so therefore, the ganglion impar, for example, wouldn't work. Your doctor, nobody really knows that because, no place in your thing has it said yet what was the diagnosis in the first place. The fact that it's a type 1 coccyx, again, that's common finding. That alone is not going to, to sort of tip the scale for whether that has, whether that's a reason at all for your tailbone pain. And then someone says that you tagged me in a post, but I didn't reply back. Yeah, again, I've been off social media, so I apologize if anybody in these last 8 months has tagged me on a Facebook post or something like that, and I have not seen those, so I apologize for that. And also recognize on Facebook I can't give you individual medical advice, of course, but I may be able to direct you to some content that may be helpful. All right. Let's see. Let's see. Can you advise for a doctor in India? Not that I know of. Can you? By the way, you should be able to get my book free in India. Although I did have somebody email me this morning from India saying that they were having trouble. So I would appreciate it if people, if you go to Amazon, if you're able to get the book for free, if you can just post a quick comment letting me know that you were able to obtain it and what country you're in. That can be helpful for me because if there is a glitch in one country or another, I can try to troubleshoot that with Amazon to make sure that it should be available worldwide. For the ebook, the electronic book version of it, I did go to the Amazon India site. It looked to me like it was free, but you have to be able to download the ebook version. You do not need a Kindle to do that. You just can download it to your computer or what have you. Let's see. Question here about notochordal cell tumor. I've only got a few minutes left here, so I'm going to say probably I'll try to post a link for tumors at the coccyx. I'll try to come back. For the ones that I don't get a chance to answer during this live session, just because it's I'm almost at an hour and a half now, I'll try to continue to post your questions, even if you're posting this after the fact, and I'll try to circle back and I can answer them. As best I can keep up with them. I'll try to answer them, just by replying to your comments, and I can either give an explanation or give you a link to some place that has an explanation. Next person says, Dr. Foye, have you had past situations with a right hip labral tear and a displaced fracture at the tailbone? Yeah, I actually have. I do have an article on hip pain in association with tailbone pain. And I slightly mentioned this earlier, but one of the things when people have midline pain at the coccyx, they sit leaning towards one side, and that's going to put a non-symmetrical right versus left pressure onto the hip joint. So certainly there are people who will have tailbone problems that also present with hip problems. Sometimes they are completely unrelated to each other, and sometimes it is in fact that one is triggering or causing or worsening the other. And then here's someone, yes, I'm 3 miles from Warrington, so you're close to. Do they still have the Warrington city gates? They were gorgeous, last time I was there, but that was, admittedly 30 maybe years ago, so it has been a while. So terrific. Do I do removal surgery? No, I'm a physical medicine and rehabilitation physician, so I'm a non-surgeon. So I do musculoskeletal medicine and pain management. I do not do the actual surgery. So for the 2 to 3% of patients who I see that actually need the surgery, We work with the patient to try to find them a surgeon in their part of the country that does the surgery. The challenging part there being that many surgeons, they do not do coccyx surgeries. They don't want to touch it. They don't want to get involved because they haven't seen it since 10 or 15 years ago when they were in residency. They're not experienced at it. And also the infection rate is pretty high. A lot of surgeons want to get in, fix something, help somebody by fixing some surgical problem, and then move on and do the same for the next patient. So it's, as opposed to get in and do the surgery and then 3 weeks later you have to go back and do more surgery because it's infected or other things. All right, so the next person is saying about MRI of the Sacrum and Coccyx. They don't do X-rays in the UK. I'll post on here. I'll post some of the links about they do X-rays in the UK for the coccyx, or at least it's authorized through the NHS. Is it possible to have nerve damage of the pudendal nerve due to tailbone dislocation? Probably not directly due to the tailbone dislocation, but they can be. Some people do have both pudendal nerve problems and tailbone problems. Again, if you go to tailbonedoctor.blog and put in pudendal, you'll find some information there. My pain is not massively debilitating, but it hasn't gone away for more than 6 years. Is it worth pursuing diagnosis? I want to rule out anything more sinister. Yeah, so, and you're in the UK. So one of the things is, there is, even if it's not like, hey, this is the worst pain of my life, there is psychological comfort that comes from knowing what's causing your problem in the first place. So I am a fan of getting an explanation and getting a reason. If you have something that's been bothering you medically for 6 years, yeah, it's good to know why that is, right? If I had blurry vision in my right eye for 6 years, I'd want to know why that was, right? If I had some, rash on the back of my, on the back of my hand for 6 years, I'd want to know, what is that? Even if I'm not going to have surgery to have that rash removed, I want to make sure that it's nothing worse, right? I want to make sure that it's not a skin cancer, or if I'm at the coccyx, you want to make sure that it's not, a mass or a tumor or something that may get worse over time. All right. Next here, coccyx pain with sitting and going from sitting to standing after fracturing tailbone during childbirth with forceps. So instrumented delivery is associated with a higher rate of coccyx pain. So pain management specialist wants to do a series of 3 ganglion impar injections, saying the relief would be permanent after these 3 injections. Would I advocate doing so many injections close together? I've only heard of doing 1 at a time. So I would say for ganglion impar injections, and I'm going to say I've probably published more about ganglion impar injections in the last probably 10 years or so than 10, 15 years probably than anyone in the country or world maybe. I don't do 3 in a row because most people don't need that, right? So my approach is, we do an injection, we see how well someone responds. The vast majority do not need a second, ganglion impar injection right away. They may never need one again. It's maybe 15% of people that need that second dose, and an even smaller percentage that would need a third dose. Within. And I don't know that I've ever done 3 within a 2-month window. I don't think I ever have. So what would be more common is to do an injection, give it a month, see how the patient's doing. Most people are not going to need 3 injections a month. That's seems excessive to me. Here's someone who lives in Australia. They're asking about telemedicine. I'm not sure. I've had actually numerous patients from Australia and New Zealand who've flown in to see me in person, but I don't know about the international aspects of telemedicine. So I will need to look into that further. Someone says I skipped their question earlier, but they haven't reposted it here. So I don't know what your question was, and I've got like an hour and a half of questions above. So if you post it again, I'll try to get to. I'm just trying to get through these as best I can. Let me see if I can do it this way. Yeah, I'm doing a find. I can't find your name showing up again. Oh wait, see thread. Maybe that'll show it.